Richter perimeter, Goldman perimeter, static, suprathreshold, and threshold. When we are called, how we call the perimeter? So perimeter, who is advised the HVF, who is offering the HVF. So there are three departments frequently advise the HVF or visual field. Number one, glaucoma, neurological disease, and retinal disease.
Nishan Surya, can you please mute yourself? Mr. Nishan Surya.
So glaucoma
Mr.
people.
Nishan Surya, can you hear me? If you have any doubt, please put it then in a chat box or mute yourself, please. Mr. Nishan Surya, can you hear me?
Background
Miss Nikki,
illumination.
please.
कहाँ से leave it? Standard Humphrey perimeter project a stimul against a background with a brightness of 31.5 ASB. If you are doing HVF, so there is a light inside the machine, that is the background of the machine. So background of the machine is 31.5 ASB. Originally used in Goldman perimetry, has adopted as a standard by International Council of Ophthalmology. So stimul duration, how much time stimul project at a machine. So stimul duration significant affect the visibility of a stimul if duration is less than 0.5 seconds or 200 milliseconds. What is the role of perimetrist and optometrist? Who is doing the HVF? There is the very important role of both perimetrist, optometrist who is doing, and the patients. The perimetrist play the central role, advise to perimetrist to undergo visual field testing themselves to better read the patient. If you are examiner, you are doing the HUF. So first you do on yourself HUF, so you can easily understand how a diamond, how a stimul look like, and what instruction explain to the patient. Important to explain the patient what to accept during the test. If you are explain well, your result will be better. If you are not explaining well, your result will not be better. Patient's tasks. So there is the many important role of the patient to parallel perimetrist and the patient. What the stimul will look like and where it might appear, how long test will last, when to blink, how to sit, how to pause the test, and so on. All things very clearly explained to patient in patient's language. Suppose patient is Telugu patient and you are explain in Hindi, so patient doesn't anything. So how we preparing the patients? First, you enter the demographic data in machine, then refractive correction. If presbyopic correction, why presbyopic correction is needed? The distance between the chin rest and the background of the machine is 30 centimeters. Okay, and we are some people doing with dilate people and some doing undilate people. Occlusion of non-testing eye. This is the monocular test, not a unicular. So you do, if you are doing right eye, so you patch the left eye, and you doing left eye, so you patch right eye. If patient is one eye, so sometimes your patient is one eye, right eye is non-visible and then no PLI, and left eye, OS eye having the vision. So should be careful. You select in your machine left eye only. Sometimes you select right eye, so there is the wrong test will go. So you occlude, I think, NPLI also for your understand. Sitting the comfortable to the patients. Ordering test. So neurological person, yeah, consultant send 30-2. So 30-2 test having the 76 localized point, and 24-2 glaucoma peoples send 24-2 and 10-2, and neurological also send the 30-2, and retina people also want to see the periphery in case of RP, so they are also advising 30-2. 24-2 having 54 points and 10-2 having 68 points. So what is the main difference between the 10-2 and 24-2 and 30-2? 30-2, 24-2, the same test, but the area 6 degrees more compared to the 24-2. But the point-to-point distance resolution, I means resolution between 2 points distance is same, 6 degree. But in case of 10-2, the area is less, central fovea to 10 degree, but the distance between two points is 2 degree. This is the main difference. Choosing stimul size. We are doing the standard size stimul 3, but the patient vision less than 20/200 or 6/60. So you should change the stimul size in full 3 threshold, stimul size 3 to 5. If you are doing in stimul size 3 standard, so patient can't see or not see for the visual for the patient. How we interpret the HVF reports. So automated perimetry is the test carried out well. Did the patient perform well? Diagnose, progression. What was done? 60-4, 30-2, 24-2, and 10-2. Strategy, threshold, screening, and what you are doing. Sita fast, Sita standard, and Sita faster. So this is the normal HVF machine report. Thank you. HVF 24-2, 30-2, and 10-2. We have Humphrey visual field Jayes machine. So again, this is 24-2, other eye 24-2, and the 10-2, and the 24-2, and 10-2. So wonder, W means what was done, A means accuracy, normal, abnormal, defect pattern, elevate, compatible disease, and review. So HVF is divided into 10 John. Some book says 8 John, some book says 10 John. So we will learn 10 John. So first John of HV is demographic data. Demographic data, machine plus patient. What is the patient? Patient MR number, name of patient, age of patient, refractive error of patient, people size of patient. And what is the machine? So stimulus size, background 31.5 ASB. As I told, strategy, which test is performed? Sita standard, Sita faster, Sita fast. So full form of Sita is sweat disk interactive threshold algorithm. Now come to the second John. Second John, here you are seeing the all reliability data is here. So fixation target should be central. Fixation loss not more than numerator 2 and denominator xyz. So 2 by xyz is acceptable. False positive, false negative. Some book says false positive, false negative 20%. Some book says 10%. But nearer to 0%, all is good. So what is false positive? Patient is not seeing the diamond or stimule but pressing the button. That is the false positive or trigger happy patient. False negative, patient seeing the stimule but not pressing the button. This is the false negative. Test duration, very important role of the test duration is in 24-2 and 30-2, 5 to 6 minutes is normal. If the test duration is more, so something is wrong. There is milestone is delay. Patient, he or she seeing the stimule, but brain is not accept the signals from the eye. So, and not giving the instruction to hand to press the button. So there is very important role of the time duration. Foveal threshold. So foveal threshold should be, if the patient is normal, the foveal threshold should be lie 30 to 40, between 30 to 40. If the foveal threshold is less than 30, so please repeat again. If the vision is normal. Suppose your vision is less, so fovea may be less. Now, John 3. This is the patient response. How much light or stimulus brightness patient accept and machine convert into the threshold and gives on the platform. This is the patient response, John 3. And this is the grayscale, John 4 of the patient response. Now the total deviation. What is the total deviation? It is the difference between the normal and abnormal. So this is the total deviation. So you want to normal data machine having the normative data in all age up to 100. So machine compare the normative data to the patient response, patient's threshold, and give us the total deviation. John 6 is the grayscale or loss of the total deviation, numerical plots. So here you are seeing in John 5, all values in minus. -4, -5, -4, -3. So we want to clarify there is the loss or not. So we have to calculate a seventh sensitive point. How we calculate the seventh sensitive point? So we take from zero side to, suppose here is the -1. So we see minus how many times is -1. So write -1, -1. Then second point is suppose -2. So you write how many times -2, -2, and then 3, then 4. So here -3 is the seventh sensitive point. Why -3 is the seventh sensitive point? So you calculate all points. So you get the on the seventh number point is -3. So you minus that -3 in all points, you get the pattern deviation. Suppose here there is the -4. So -4 plus minus minus plus. So -4 plus 3 is equal to -1. And here is the -5. So -5 minus minus plus 3. So -5 plus 3 is equal to -2. All around 95% points is follow these 7 sensitive rules. But some periphery points not follow this rule because the threshold is decreasing central to periphery. Now the 8th zone. So 8th zone is the grayscale of the pattern deviation. If the central 4 points in pattern deviation, you get any of these population study down 3. So you should do the 10-2. You perform 10-2 because your diffraction or field loss under the field of 6 degree. So you need to do the 10-2. Why 10-2? In the 10-2, each point is equal 2 degree of interval, 2 degree of difference. So central to point is 1 degree. Here is 1 degree. So you can easily enhance the 1 degree, catch the 1 degree field also. So then the ninth gauge, ninth zone. So there is the mean deviation. Mean deviation is the total deviation. You count all total deviation points, add all points, and divided 54 in 24, 54 in 24-2, 68 in 10-2, and 76 divided by 76 in 30-2. So you get the mean deviation here, this value. And pattern standard deviation, you add all these points and divided 54 like total deviation, you get the mean deviation. And then you get the result, GHT, glaucoma hemi test. This is normal, outside normal limit, or journal reduction. So how we read the printout, how we read the report, like this. So reliability index, fixation loss, false positive, false negative are flagged. So this is the zone. I will explain already all zones. So no need to again. This is the fixation losses and false positive, trigger happy patient, and false negative. Normally or abnormality. A cluster of 3 or more points diffract less than 5 dB compared with surrounding points is suspicious. If, for example, if you get the 30 threshold at 1 point, so surrounding points not less than or more than 5 degree, 5 dB. A single point depressed 10 dB, more than 10 dB is very usual, but it is of less value on a single visual field than a cluster because cluster points for one another. Corresponding points above and below the line. Suppose one point is above the line, one in the below the time is not depressed visual field 1 to 2 dB.
I request Dr. Wasim, please mute yourself.
So this is the total deviation. The difference between these, all John explained. So carefully, advanced glaucoma, clear media, and happy trigger patients. See, here is the 17 years lady, clear media with advanced disc cupping. So you see here all is 0, loss all visions. There is tubular vision is here only 2 or 3 degree. This is you are seeing the white scotoma. This is the trigger happy patient. So they are not seeing any stimulus but pressing the button continuously. So we get the sensitivity 58, 47. So you get the here white scotoma. Typical area of white scotoma look like this. And paracentral scotoma like this. Here you are seeing the defect in inferior, so you get the loss in superior. This is the arcuate scotoma. Nasal step glaucoma, so you see here the loss. This is the altitudinal defect. Here you see the inferior defect, and in HUF you see the superior defect. Arcuate scotoma, so you see 2 arcs. Clover leaf defects. Very carefully, this type of patients, first you do the start test, then patient very happy and pressing button continuously, and after that patient tired, so cannot press the button, so look like a clover leaf defect. This is the peripheral artifact due to the high plus or high minus power. So when you are putting the lens in trial frame in HVF, so the power is high. So please set the lens nearer to the eye, not away from the eye. If you are putting the lens away from the eye, so you get this type of artifact. So repeat HUF again. See here. Elevated patch, white scotoma. White scotoma is here due to the false positive, GHT positive, PD, high mean deviation, pattern deviation, total deviation, and unless result plan instructed to reset. See here the one patient photographs. This is the left eye, and this is the color free or red free photograph of same eye. So this is the HVF of same patient. See here you are seeing the superior laser marks, the HVF of same patient. So you seeing here inferior is loss of sensitivity. You see here the choroidal coloboma in inferior. So there is the defect of superior in HVF. Artifact, see here you periphery, there is the artifact. This is the normal patients. Same patient, we repeat the HVF, so we get both eye normal. Thank you. My next,
Thank you so much, sir. Thank you so much, sir, for this wonderful session. If anyone have any questions, then please type them in the chat box. Sir, there is a question from Lian Sweeney. Sir,
yes,
kindly explain about Anderson's criteria in brief.
Anderson criteria is as you know the bundles, how RNFL bundles look like. Okay. So this is depend on the RNFL bundles, and the shape of the HVF also depend on the Anderson.
Anyone have any other doubt? Yes, sir. From Gopichand Sahu, there is a doubt. Sir, when we will decide to increase the stimulus side?
If the patient vision is less than 20 by 200 or 6 by 60, so you should increase the stimul size up to 5. But you cannot get stimul size in standard or Sita faster. You go to strategy window and select full threshold. So full threshold, select full threshold, then you can change the stimul size. But you are not selecting the full threshold, so you cannot change. This is the manufacturing of machine.
Yes, sir. There is one more question from Dr. Sanjay Mehta, sir. Role of diurnal variation in the outcome of results.
The if you are doing the various doing the intraocular pressure whole day, 1 hours or 2 hours interval, then you calculate all reading in evening, then you make a treatment.
Okay, sir. From next question is from Isa Ahmed. When to consider the visual fields as concerning?
When first you see the patient fundus, if you suspect the disc, there is 3 types of disc: small, medium, and large. So carefully you see the RNFL and the disc. You, if your curve disc ratio is nearer to 5.5 or more than 5, if there is physiologically or glaucomatically, so you do first the baseline HVF 24-2. If you are doing in neuroclinic, so there is the papilla edema or disc pale, so you go for baseline 30-2 HVF.
Okay, sir. There is one more question from Munesh Hope. Are there age limits in HVF or do we change strategy for different ages?
No, your patient, suppose patient age pediatric age group is 5 years of age, can understand your things, what you explain, so you can do. There is no age limit. But less than 5 years, it is too difficult to explain the patient. Any old age patients, paralytic, but hands is not working, patient is not listening, so unnecessary you not travel the patients.
Okay, sir, thank you. I think there is no more questions from HVF. Now you can further proceed to B scan.